Lie down on your right side. Right now, if you can manage it, take a slow breath in through your nose. Hold it for 2 seconds and pay attention to where the air seems to go. Now roll over. Onto your left side. Same breath. Same hold. Feel the difference. There is one. You may not have noticed it before, because the brain is a cunning little hiding place for asymmetries it does not want you bothered with. But the difference is there. It is real. And it is governed by physics. Now here is the thing I want to tell you about. Most people, when they picture their lungs, picture 2 identical bags. Pink, symmetric, same shape, same size, same job. And that picture is wrong. It is so wrong that it produces measurable consequences for how well you breathe, how hard your heart works, how your nervous system settles down at night, and whether the doctor at the hospital decides to roll you onto one side or the other when your blood oxygen starts to drop. So today I want to walk through what is actually happening inside your chest when you turn from one side to the other. Not the cartoon, the real machinery. And I want to show you why the side you sleep on is not a matter of preference, but a matter of mechanics. Let me first take you on a small tour of the architecture, because if you do not know the rooms, you cannot understand the air that moves through them. Inside your chest, behind the breastbone, you have 2 lungs. They are not the same. The right lung has 3 lobes, upper, middle, lower, and it occupies roughly 55% of the volume available in the thoracic cavity. The left lung has 2 lobes, upper and lower, and only 45% of the volume. There is a reason for the difference. Something else lives in the left side of your chest. Your heart. Your heart sits not in the middle, but rotated and tipped to the left, with about 2/3 of its mass on the left side of your sternum. It weighs somewhere between 250 and 300 grams in an adult, about the weight of a cup of yogurt. And it is a wet, slippery, muscular bag that has been beating without rest since you were a fetus the size of a kidney bean. Now this heart, sitting where it sits, has cut a notch out of your left lung. The notch is called the cardiac notch, and you can see it in any anatomy textbook. The left lung leans backward and away from the heart, leaving a hollow on its anterior surface where the heart can pulse without being touched. So the lungs are asymmetric not because of some accident, but because the heart had to fit somewhere, and your left lung gave up some of its territory so that the heart could have a place to live. Between the 2 lungs, holding everything in place, sits a curtain of connective tissue called the mediastinum. It contains the heart, the great vessels, the trachea, the esophagus, the thoracic duct, the phrenic nerves, and the vagus nerves. The whole junction box of your torso, packed into a column the width of your fist, and the mediastinum is held in the center of your chest by tension, by the negative pressure of the 2 pleural cavities pulling outward in opposite directions, like a tent rope tied between 2 trees that lean away from each other. Take that tension away, and the mediastinum sags. We will come back to this. Below all of this sits the diaphragm, a dome of muscle attached to your lower ribs and your spine that pulls downward when it contracts and pushes air into your lungs. The diaphragm is not symmetric either. The right side of the dome sits higher than the left side by about 1.5 to 2 centimeters, because directly beneath the right hemidiaphragm sits the liver, which weighs about 1.5 kilograms and pushes the dome upward. The left hemidiaphragm has only the stomach and the spleen pushing up against it, and they are lighter. This is the architecture, asymmetric on every floor. Now let me show you what happens when you lie on your right side, and what happens when you lie on your left. Roll onto your right side, right hip down, left arm draping across. The first thing to know is that gravity, which has been pulling vertically downward on your body all day long, is now pulling horizontally across your chest. The structures inside your chest cavity are no longer stacked. They are stretched sideways, leaning toward whichever side is dependent. And the heaviest structure in your thorax, the one that weighs as much as a small grapefruit, is your heart. When you lie on your left side, your heart, which already sits 2/3 in the left side of your chest, slumps further to the left. It presses outward, downward, against the floor of your dependent left lung. The lung underneath your heart gets squeezed. Not crushed, the mediastinum still holds the heart somewhat, but squeezed. There is a measurable area of left lung tissue that is collapsed, atelectatic when you lie on your left side, because the weight of the heart has pushed the air out of those alveoli. This is not speculation. It was measured directly by Tatsuhiko Yamashita and his colleagues in Japan, who put healthy subjects into a magnetic resonance imaging scanner in different positions: supine, left side lying, right side lying, semi-prone, and outlined, slice by slice, the area of lung that the heart was sitting on top of. They called it the compressed volume of lung by the heart. They published their measurements in the Journal of Physical Therapy Science, and the difference between left lateral and right lateral is not subtle. When you lie on your right side, your heart shifts. Not far, but it shifts away from the dependent right lung, falling forward and toward the sternum, because the mediastinum lets it sag in that direction. The dependent right lung, even though it is the bigger lung, with 3 lobes instead of 2, sits underneath a heart that is tilted away. The compression on the right lung in the right lateral position is dramatically less than the compression on the left lung in the left lateral position. Now think about what this means. You have just discovered that the heart, which you thought was a polite tenant living in its own apartment in your chest, is actually a heavy guest who leans on whichever lung is below it. And it leans hardest on the left lung, because the left lung is closer. The lung you are lying on, when you lie on your left side, is being asked to do its job of inflating and deflating against the steady downward pressure of 300 grams of muscle. Lie on your right side, and that pressure shifts off the dependent lung and falls instead toward the sternum and the bedding. The lung underneath you on the right has more room to expand. The whole bigger lung is freed up to take in air. That is mechanism number 1. The heart presses on the dependent lung. Lying on your right shifts the weight away from the part that is doing the work. The structure that is being compressed is not only the lung tissue, it is also the floor of the chest cavity. It is also the diaphragm. When you lie on your right side, your liver, that 1.5 kilograms of dense blood-filled organ tucked just under your ribs on the right, falls toward the floor along with the rest of your right side abdominal contents. And as it falls, it pushes upward against the underside of the right hemodiaphragm. The dome of muscle that drives your breathing on the right side becomes more domed, more curved, more like a high-pitched roof than a flat ceiling. This sounds like a small detail. It is not a small detail. Let me show you why. The diaphragm is a pressure-generating muscle, and the pressure it generates when it contracts depends not only on how strong it is, but on the curvature of the dome. There is a law in physics called Laplace's law, which says that for a curved membrane under tension, the pressure across that membrane is proportional to the tension and inversely proportional to the radius of the curve. A small radius, a tightly curved dome, generates more pressure for the same muscular tension. A large radius, a flat dome, generates less. A diaphragm that has been pushed up into a high curve by the abdominal contents below it is a diaphragm that pulls harder on each contraction. This was measured. Andrew Whitelaw and his colleagues did the experiment using magnetic resonance imaging, and they reconstructed the 3-dimensional shape of the diaphragm in living subjects. They calculated the tensions in the right and left hemodiaphragms separately. The tension in the right hemodiaphragm, with the liver pushing it upward, was about 54 grams per centimeter. The tension in the left hemodiaphragm, with no liver underneath it, was about 32 grams per centimeter. The right side, by virtue of having a heavy organ beneath it, is mechanically prepped to pull harder. You lie on your right side, and the liver falls toward the floor. It pushes upward harder than it does when you are flat on your back. The right diaphragm becomes even more curved than usual, and by Laplace's law, that more curved muscle generates more pressure per contraction. The non-dependent left lung, the one up in the air, the smaller one, gets ventilated by a diaphragm that is now pulling at its mechanical optimum. It is not that the right hemodiaphragm became stronger when you rolled. It is that you put it into the geometry where its existing strength produces the most pressure. The muscle did not change. The shape did, and the shape is everything when you are dealing with curved membranes. Anyone who has tried to inflate a half-deflated balloon, then a fully deflated one, knows this in their fingers. The first one is easy. The second one is hard. Same balloon. Same lungs. Different curvature. This is mechanism number 2. The right side of your diaphragm is mechanically tuned to perform best when your right side is dependent. Your body has a power stroke, and the power stroke is on the right. The same gravity that pulled your heart toward the sternum and your liver toward the floor is also pulling on something else inside your chest, your blood. You probably remember from somewhere in school that blood goes from your heart to your lungs, picks up oxygen, comes back and goes out to your body. What you may not remember is that the way blood is distributed inside the lungs is governed almost entirely by gravity. When you stand up, blood pools in the lower parts of your lungs because gravity pulls it downward. The base of each lung gets more blood than the apex. When you lie flat on your back, the back of each lung is now the dependent part, and the back gets more blood than the front. When you lie on your right side, the right lung, which is now the dependent one, gets significantly more blood than the left lung. The number, from cardiac magnetic resonance studies done in healthy subjects by a research group in Lund, Sweden, is that pulmonary blood flow shifts by 16 to 33% toward the dependent lung when you change position from supine to lateral. A third of the lung's blood supply, redistributed by gravity alone. Now think about this. When you lie on your right side, more blood goes to the right lung. The right lung is the bigger lung. The right lung has 55% of your alveoli. So you are sending the bulk of your blood to the bulk of your gas exchange surface. The match between ventilation and perfusion, what physiologists call the V/Q ratio, is favorable. When you lie on your left side, more blood goes to the left lung. The left lung is the smaller lung. It has only 45% of your alveoli, and it has a heart sitting on top of it, compressing some of those alveoli closed. You are sending more blood to a smaller, partly compressed gas exchange surface. The match is worse. The clinical consequences of this matching were demonstrated all the way back in 1974 by a doctor named Michael Zak, working with Henning Pontoppidan and Homayun Kazemi at Massachusetts General Hospital. They took patients with disease confined to one lung and rolled them between left and right lateral positions, measuring the oxygen content of the arterial blood after each turn. They found that when the healthy lung was dependent, the good lung down, the patient's arterial oxygen pressure was around 144 millimeters of mercury. When the diseased lung was dependent, it was around 86. A difference of nearly 70% in blood oxygen, achieved by rolling the patient over. This finding was confirmed in 1981 by Carl Remolina and his collaborators at New Jersey Medical School, publishing in the New England Journal of Medicine, who described the phenomenon and gave it a name: positional hypoxemia. They showed that the effect was dose-dependent. The worse the unilateral disease, the bigger the effect of position. And they recommended that hospitalized patients with one-sided lung disease be positioned with the healthy lung dependent whenever possible. So the principle has been in the literature for 50 years. Good lung down, bad lung up. And here is the embedded truth of that principle for a healthy person. In a body where the right lung is bigger and less compressed than the left, the right lung is, on average, the better lung. Lie on your right, and you put your better lung in the position where blood flows most generously. That is mechanism number 3. Gravity routes blood to the dependent lung. When the dependent lung is the bigger one, the matching is better. I have told you about 3 mechanisms now: the heart's weight, the diaphragm's curvature, and the blood's gravity-driven redistribution. And they all point in the same direction. Right side down is mechanically better for breathing than left side down. But there is a 4th thing happening, and it is happening to the rhythm of your heart itself. And it is more interesting than any of the 3. When you lie on your left side, the heart, as I told you, slumps toward the chest wall. It is now closer to the rib cage, closer to the skin. Mechanoreceptors in the heart wall and in the great vessels, the little stretch-sensitive nerves that feel the pressure of blood inside the chambers, are pulled into a slightly different position. The vagus nerve, which is the main cable of your parasympathetic nervous system, has to negotiate around all of this. It carries signals from the heart back to the brainstem, telling the brain how the heart is feeling. And the brain, listening to those signals, decides how much to relax the heart and how much to drive it. In 1997, a research group led by Yamamoto in Japan did a clean experiment. They took healthy subjects, laid them in 3 positions: supine, left lateral, right lateral, and recorded the heart rate variability in each one. Heart rate variability is a measure of how flexibly the heart responds to nervous system input. High variability means the parasympathetic system has good tone. Low variability means the sympathetic system is dominant. Your fight or flight system is winning. They found that in the right lateral position, the high-frequency component of the heart rate variability, the part that tracks parasympathetic, vagal tone, was the highest of the 3 positions. The sympathetic activity was the lowest. The body's relaxation system was most active when subjects lay on their right side. This was confirmed almost 3 decades later in a much larger study using 24-hour ambulatory egg recordings from over 130,000 subjects in Japan in a database called All-Star. The investigators looked at heart rate during sleep posture across all 4 positions: supine, left lateral, right lateral, prone, and the heart rate was consistently lowest in left lateral and highest in right lateral. But the high-frequency variability, the parasympathetic signal, was strongest in right lateral. Let me say in plain language what that means. When you lie on your right side, the brain's parasympathetic, calm the system down output to the heart is at its strongest. The heart beats slightly faster, but with greater variability, a sign of a healthy, well-regulated autonomic system. When you lie on your left side, the parasympathetic output is reduced, and the heart, even though it is beating more slowly, is doing so under more sympathetic, stress-related drive. There is something about right side recumbency that the brainstem reads as safe. That is mechanism number 4. The right lateral decubitus position is the position of strongest vagal tone. I have to pause here and tell you what we know and what we do not. Because if you go diving into the literature on body position and lung function, you will find studies that contradict each other, and you will find conclusions that are stated more confidently than the data warrant. So let me walk you through what is established and what is still being argued. I will give you each claim and tell you, frankly, how solid the ground is underneath it. First claim: the compression of the dependent lung by the heart. Solid. Yamashita and his colleagues measured it directly, in MRI images. The effect is real, it is reproducible, and you can see the lung area that the heart sits on. That area is consistently larger when the dependent side is the left. Second claim: the redistribution of pulmonary blood flow toward the dependent lung by gravity. Solid. It has been measured by injected radioactive tracers, by cardiac MRI flow studies, by every technique in the book. The dependent lung gets more blood. The number is 16 to 33% more. Third claim: the improvement in oxygenation when the healthy lung is placed down in patients with unilateral lung disease. Most solid of all. Replicated in study after study. Zach in 1974. Remolina in 1981. Gillespie and Rader at the Mayo Clinic in 1987. Multiple intensive care unit trials in the years since. The effect is robust. Hospitals use it as standard practice. Fourth claim: the vagal tone benefit of the right lateral position. Real, but smaller. The heart rate variability differences between sides are consistent across multiple studies, but the effect sizes are modest. It is real. It is a tap on the autonomic system, not a slap. Fifth claim: the benefit for healthy people who do not have lung disease, sleeping at night. This is where the literature is thinner. The mechanisms apply equally. The principle is the same. But few studies have looked specifically at whether a healthy adult, sleeping 8 hours on the right versus 8 hours on the left, has measurably different blood oxygen levels in the morning. The mechanistic case is strong. The direct sleep study case is suggestive, but it is not yet conclusive. There is one more thing I should tell you. Medicine has a phenomenon called trypopnea. That is the word for being short of breath only in one lateral position. Patients with chronic heart failure especially those whose hearts are enlarged, develop this. They cannot lie on their left side without feeling like they are suffocating. They roll instinctively to their right. Pinto Filho and a Brazilian research group studied this and reported that something like 50% of decompensated heart failure patients have measurable tropopnea, and that they preferentially develop fluid collections in the right pleural space because they spend so many hours lying on their right side. In other words, the people whose hearts are most stressed, in the moment of greatest stress, choose the right side. It is not a cultural preference. It is a physiological gravitation. The body, given the choice, drifts to the side that is mechanically easier. So when I tell you that your lungs work better on your right side, what I mean is this. The mechanisms by which they would work better are well established. The clinical effect in sick patients is dramatic. The autonomic effect in healthy people is real, but small. The total effect on a healthy person sleeping at night is suggestive, strong enough that many cardiologists already recommend right-side sleep to their heart patients, weak enough that no one is going to write a prescription for it. Take the principle. Apply it. Notice if you feel different. Now I want to do one more thing before I close, which is to point at something I find funny in the awkward, almost painful sense of funny. There is a device called a continuous positive airway pressure machine, a CPAP. It uses an air pump and a mask to push air gently into your airway while you sleep. It is prescribed for sleep apnea. It is also used, in modified form, to improve oxygenation in patients with mild respiratory failure. A CPAP machine costs somewhere between $500 and $3,000. Insurance pays for some, not all. Replacement masks and tubing run another $200 to $300 a year. There is also a device called a BiPAP, bi-level positive airway pressure, which provides two different pressures, one for inhalation and one for exhalation. A CPAP with more controls. A BiPAP machine costs between $1,500 and $4,000. And there is supplemental oxygen, delivered by tank or by concentrator, which costs hundreds of dollars per month for the patient who needs it at home. These are real interventions. They save lives. They are necessary, and I am not telling you to throw them away. The medical device industry is not selling air for nothing. There are people whose lung function is so compromised that the only way to keep their oxygen up is to push the air in mechanically. But here is the funny part. In an intensive care unit, when a patient with one-sided pneumonia is starting to lose blood oxygen, the first thing the bedside nurse does before anyone reaches for the machine on the wall is to roll the patient. Good lung down. The position change can produce, in some patients, an arterial oxygen improvement of 50 millimeters of mercury or more. That is a clinically meaningful gain in oxygenation, achieved by the simplest intervention in medicine. Rotation. The intensive care nurse is doing, with her hands in a pillow, something whose mechanical principle is closely related to what the CPAP machine attempts to do at scale. She is changing the V over Q matching. She is recruiting alveoli that were previously closed. She is shifting the heart's weight off of compressed lung tissue. She is acting on Laplace's law, on gravity, on cardiac mechanics, all at once. And the machine on the wall, costing thousands of dollars, sits unused for the next 15 minutes because the rotation was enough. Picture the person in their late 60s, diagnosed with mild congestive heart failure 2 years ago, has been told to use a CPAP machine, has been told to elevate the head of the bed, has not been told anything, by anyone, about which side to sleep on, has been waking up at 3 a.m. short of breath, has been rolling onto the side that feels easier, has been writing it off as restlessness. The body was already doing the math. Nobody told the body it was right. When you go home and sleep on your right side, you are using the same physics the nurse is using. The dose is smaller, because you do not have pneumonia and you do not need supplemental pressure. You are not getting 50 millimeters of mercury of arterial oxygen improvement. You are getting maybe a few, enough to mean that your dependent lung is more efficient, your diaphragm is more domed, your heart is more vagally regulated. A modest improvement, multiplied by every night for the rest of your life. Free, drawn from your own anatomy. The dose is small. The principle is the same. There is one more thing I want to tell you, and it is the thing I find most interesting. When my mother's mother was alive, she used to tell me that I should sleep on my right side. She said it was better for the heart. She said it was the way her own mother had slept, and the way her mother before her had slept, in a village where no one had ever heard the words magnetic resonance imaging or arterial oxygen partial pressure. I remember being told this and thinking it was an old woman's tale, something the elderly believed because they had always believed it. But now I have walked you through 4 mechanisms: cardiac decompression of the dependent lung, mechanical priming of the right diaphragm, favorable ventilation perfusion matching, and parasympathetic dominance, every one of which says the same thing. Right side. The thing my grandmother said. The thing women in her village said long before anyone owned a CPAP machine, long before anyone had measured a heart rate variability spectrum, long before there was a New England Journal of Medicine to write the principle down. They did not know in the way that I know now. They could not have measured cardiac compression with a magnetic resonance imager. They could not have plotted vagal tone against position. They had no instruments, but they had something else, which is the distilled experience of millions of human bodies, sleeping in millions of nights, asking themselves the simple question of whether tonight was a good night. The bodies that woke up, rested on the right side, told their owners. The owners told their daughters. And the principle, abstracted from millions of mornings, came down to me as a small piece of advice from an old woman holding my hand in a kitchen. This is not the only case where folk knowledge encoded a real physiological mechanism. It is one of many. But it is one I find pleasant to think about, because the science I have just walked you through has nothing to refute, and almost everything to confirm what your great-grandmother knew without instruments. So I want to leave you with one direct instruction. The next time you go to sleep, lie on your right side. Take a slow breath in. Feel where the air goes. Notice that one lung is up and one lung is down, that the heart has rolled toward the sternum, that the diaphragm beneath you is more domed than it was a minute ago, that the brainstem is registering safety and turning down the volume on your fight-or-flight system. None of this is mystical. All of it is mechanics. Tell me, if you would, what side have you been sleeping on, and now that you know what is happening underneath you, what are you going to do tonight?